great. All right. Well, thank you and good afternoon. I am at home today. It is a holiday in the US, so I apologize if any dog or child comes running through while I'm speaking. That's my first disclosure. I was not a part of any of the vamorolone trials. I've done some advisory boards for both Catalyst and Synthera for the rollout. I also get funding from Enzyme, but that's not related to Duchenne. I also want to just briefly acknowledge that I'm a member of the Optimizing Endocrine and Bone Health Management in DMD Consortium. This is a group of clinicians working with Parent Project Muscular Dystrophy, includes people from the UK, from Canada, and the US. You'll hear from more of our members tomorrow, I know, but I will be mentioning this throughout my talk. So just really two objectives for today. I just want everyone to be able to understand the differences between vamorolone with the brand name Agamree and classic glucocorticoids, and then be able to develop or implement a plan for the management of adrenal suppression in people treated with vamorolone. I just wanted to do a very quick review first of vamorolone versus classic corticosteroids and some of the differences and similarities. So I think one of the things that's challenging is the terminology around the use of the word steroids in clinical care. I use the word corticosteroid here because that's really what we're talking about. These are synthetic analogs of the endogenous hormone cortisol, which is made by the adrenal cortex, hence corticosteroids. Typically, our bodies do make cortisol at a low amount every day, which we refer to as maintenance steroid production. And then, of course, the steroids that are relevant for use in clinical care in Duchenne and Becker is hydrocortisone, prednisone, and deflazacort. These all act through both the glucocorticoid and the mineralocorticoid receptors, hence the word glucocorticoid. And it's that signaling through the glucocorticoid receptor that causes all the sort of typical things we think about with steroids. So that's the anti-inflammatory action, the increase in blood sugar, the elevation of mood, also the alterations in bone metabolism and growth. The mineralocorticoid receptor, or the MR, you may not think about as much, but this is what really helps support blood pressure and electrolytes during stress. So next we have vamorolone. So this is really the first in class of the dissociative corticosteroids that's come into clinical care. Again, it's a man-made or synthetic steroid. And the goal here really is to dissociate the two main mechanisms of actions of these corticosteroids. And so the first is something called transrepression. This is the main mechanism by which a steroid causes anti-inflammatory activity, and that is maintained with vamorolone. The second is something called transactivation. This is a different mechanism that is thought to be responsible for many of the side effects. And so vamorolone causes less transactivation. So the goal is a steroid here that has anti-inflammatory benefit with less side effects. So how does that work? So just a real quick look at the structure of vamorolone versus our classic corticosteroids of prednisone and deflazacort. First glance, you will see, wow, they all look very similar, just emphasizing again that vamorolone is in fact a steroid. But on closer look, you can see there's a very small structural change here, looking at the bonds of these two carbon atoms. So prednisone has a carbonyl bond, deflazacort has a hydroxyl bond, and then vamorolone actually has neither. It has a double carbon bond there. So it's this small difference in structure that changes the activity and the function of vamorolone. It does that in three ways. It does it through that partial agonism of the glucocorticoid receptor. As I mentioned, retained transrepression with reduced transactivation. It blocks the mineralocorticoid receptor. And then finally, it's resistant to an enzyme called 11-beta hydroxysteroid dehydrogenase. This is important because this enzyme is thought to be responsible for some of those side effects in off-target tissues like bone. All right, so that's all well and good, but so what are the clinical implications of vamorolone? So here's a table from a handout that we have put together, and it's available on the PPMD website, which I will share later at the end. So this table illustrates the side effects of vamorolone compared to classic steroids of prednisone and deflazacort. So first, vamorolone clearly causes less growth suppression. We know that from the clinical trial data. Unfortunately, it does still cause weight gain, still causes about the same amount of weight gain as prednisone in the clinical trials. And this in clinical practice means that these patients do tend to gain more weight than the people on deflazacort. It's probably better at the bone. So in the clinical trials, there was less suppression of bone turnover and starting to see some numerical evidence of less vertebral fractures. We don't yet know how it affects puberty. It seems to be better on mood and behavior, but we don't have really published data on this yet. No information on development of cataracts yet. And then importantly, and what I'll talk about for the remainder of this talk, is vamorolone still does cause adrenal insufficiency. So for the remainder of the talk, then we'll talk about how to manage adrenal suppression due to vamorolone. And our group at Optimize has really put together these 6 critical concepts to guide the prevention and treatment of adrenal insufficiency. I should say that these apply to all steroids, not just vamorolone, but for the purpose of today's talk, we're going to focus just on vamorolone. So the first critical concept is that individuals taking vamorolone for greater than 2 weeks are at high risk for adrenal suppression. So here's a figure showing the hypothalamic pituitary adrenal, or the HPA axis. So normally, in normal function, the part of the brain called the hypothalamus secretes something called corticotropin-releasing hormone, which acts on the pituitary to secrete adrenocorticotropin hormone, or ACTH. ACTH, in turn, stimulates the adrenal gland to make cortisol. So anytime anyone takes a steroid, such as deflazacort, prednisone, or vamorolone, that provides negative feedback to both the hypothalamus and the anterior pituitary. And that results in atrophy of the adrenal gland, as you can see here with our sleeping adrenal. Typically, cortisol production rises during stress. This is called the stress response. And this is important because adrenal insufficiency is a potentially life-threatening complication of adrenal suppression. So when someone is taking extra steroids, the body is unable to mount its own stress response, and so we have to provide that for them. This just takes some figures from the clinical trial data, just showing that vamorolone does cause adrenal suppression. This first graph illustrates that vamorolone suppresses that maintenance cortisol production. This is done by measuring morning cortisol. You can see the blue line here is a placebo, so morning cortisol production remains normal across 24 weeks. In patients who are subjects who were started either on low or high dose vamorolone or on prednisone, you can see that drop in cortisol levels in the morning. That is dose dependent. You can see those at the higher dose of vamorolone were suppressed more than those on lower doses. That isn't so clinically relevant. The key take home here is that vamorolone suppresses that physiologic or maintenance cortisol production. And then this graph shows that vamorolone also suppresses the stressed cortisol production. We measure this using something called an ACTH-stimulated cortisol level. So ACTH is given in a controlled setting, and we measure cortisol at 30 and 60 minutes. Anything above these dotted lines would be a normal stress response. And so you can see individuals who received the placebo mounted a normal stress response. Those who received prednisone or vamorolone at either dose had low stress responses, so had adrenal insufficiency. Critical concept number 2, signs and symptoms of adrenal insufficiency are often nonspecific and may only develop during times of physiologic stress. So here's a table sort of highlighting the signs and symptoms of adrenal insufficiency. So the ones that we often think about are nausea, vomiting, anorexia, but importantly, they also can show up as weakness or fatigue. And of course, there's a lot of overlap with the symptoms of DMD, of weakness and fatigue, and adrenal suppression. So it's important to always educate families about this possible symptom that could be adrenal suppression and not just a complication of DMD. And then the clinical signs, so when the patient's in clinic or in the emergency room, we're really looking for things like hypotension, hypoglycemia, change in heart rate, and sometimes even fever. And the take home here is really we want all individuals and their caregivers to be educated about these signs and symptoms at the time that clinical steroid use is started. Uh, Concept number 3, all individuals taking vamorolone must have a stress steroid plan for moderate and severe physiologic stress. And just to be clear here, we're not talking about emotional stress. We get that question a lot. We're really talking about that physiologic stress affecting the body. So we define moderate stress as things like a fever, an illness that keeps a child home from school or an adult from going to work. Mild vomiting, so this would be that situation where you throw up once, still able to hold down that steroid medicine, not continuous. Mild diarrhea, a fracture that does not break the skin, and then increasingly we're seeing moderate stress from bisphosphonate infusions. These are medicines we give to treat osteoporosis, and they can cause a fever, so that's important to educate families about. And then in contrast are severe stress situations. So this is that severe vomiting, so repetitive vomiting and unable to keep those medicines down, severe diarrhea that may affect the absorption of the steroids, altered level of consciousness, car accident, other major trauma, a broken bone that breaks the skin, or any medical procedure that's requiring general anesthesia. And so everybody on vamorolone must have a stress steroid plan. Importantly, vamorolone cannot be used as a stress steroid. So even though these patients are on very high doses of vamorolone, it's above the physiologic or maintenance levels. Remember, it is blocking the action at that mineralocorticoid receptor. And so that means during times of stress, they're at risk of low blood pressure and electrolyte abnormalities. Vamorolone also has a very short half-life, so that once daily dosing isn't going to cover steroid needs for the entire day. So what we recommend is that everybody on vamorolone have a moderate stress steroid plan of either hydrocortisone given orally 3 times per day, or prednisone or prednisolone given 2 times a day. These stress doses are given in addition to vamorolone. Those can be based either on weight or body surface area. It's a little bit too complicated to go into for this talk, but I have references that can guide you in that area coming up. And then you're going to have patients continue taking that stress steroid dose until the illness or the stressor has been resolved, plus an additional 24 hours. And then for severe stress, the hydrocortisone is going to be given either as an injection into the vein in the hospital or into the muscle at home. Here, I just want to highlight some very nice work coming out of the British Society for Pediatric Endocrinology and Diabetes. This is a little handout that illustrates the stress doses of the injectable hydrocortisone at different ages. So it's important that all patients and the caregivers receive hands-on education on how to give an emergency steroid injection at the time that the vamorolone is first prescribed. And then really this should be reinforced annually. And then also very important to communicate these stress steroid plans. So the recommendation is that to have these documented in the electronic health record for use by different hospital and healthcare settings. And then also to encourage families to carry an emergency card, perhaps wear a bracelet or a wheelchair tag that identifies them as being steroid dependent. Critical concept number 4, all individuals stopping vamorolone therapy should complete a taper. So steroid tapers are important for anyone taking chronic steroids, and that's because a sudden discontinuation of vamorolone or other steroid is not safe. It can cause symptoms and signs of something called adrenal withdrawal. This is not life-threatening, but can be very troublesome. Patients can have really severe headaches, significant fatigue, nausea, malaise, and sometimes in the setting of Duchenne, we see some sort of transient sort of increase in muscle weakness. But importantly, during this time, they're at a very high risk of adrenal insufficiency, particularly during those times of physiologic stress. So as a result, we want to do a taper or a slow decrease in that steroid dose to reduce the risk of these complications. Importantly, stress steroids must continue until the adrenal recovery is confirmed. So in terms of how to do a taper, there's not really a standard approach. This is one of these examples where you really want to discuss with your local endocrinologist. Many institutions have their own protocols or pathways for safely tapering steroids. Because vamorolone may not be in those pathways, we have put together a couple of different methods for safely tapering vamorolone. The first one is to consider just adding a background hydrocortisone at a maintenance dose. So when someone is going to taper off vamorolone, you ask them to take hydrocortisone 3 times a day at a low dose. And then you can safely wean off that vamorolone, maybe decreasing by 1 mg per kilo per dose every 1 to 2 weeks until off. A second approach, which might be better if someone is maybe having side effects of vamorolone and you want to get them off quickly, you can actually just switch them straight from vamorolone to a stress dose of a hydrocortisone or a prednisone, so still at a high level of steroids. And then you can decrease that dose of the hydrocortisone or prednisone by 10 to 20% every 1 to 2 weeks until tapered off. And this would be sort of a more standard way that we typically taper classic glucocorticoids. Didn't have time to go into sort of detailed examples, but we have an updated steroid management protocol called the PJ-Nikolov protocol, which you may be familiar with, which was recently published and online at PPMD as well. Critical concept number 5, individuals tapering off vamorolone must continue to take stress steroid doses until recovery of the HPA axis has been confirmed. So it actually can take a long time, 6 to 12 months or even longer, for that adrenal function to fully recover. During that period of time, individuals are going to remain at risk of adrenal withdrawal and adrenal insufficiency, and so they must continue their stress doses. An endocrinologist can sort of help with assessing recovery of the HPA axis. As you saw from those graphs from the clinical trial, that can be done in 2 ways. The first is by checking that morning cortisol on a simple blood test. And the second is by doing that stimulated ACTH test. So how do we do this? So by checking a morning cortisol, we're looking for a cortisol level of above about 300 nanomoles per liter or 10 micrograms per deciliter. If you have that level, you know the axis is recovered and you can stop your stress dosing. If that morning cortisol is below that level, the axis is still suppressed and you need to continue stress dosing, and you can retest again, perhaps in about 6 months. If you continue to not see those cortisol levels rising in the morning, then perhaps it's time to move on to the stimulation test. In this case, we're looking at that peak response and looking for a cortisol level of above 400 nanomoles per liter or 14.5 micrograms per deciliter. Again, you get there, axis is recovered, you can stop your stress dosing. If you're below that, again, continue your stress dosing and can test again in about 6 months. All right, our final critical concept is to use care when transitioning from one glucocorticoid regimen to another to reduce the risk of adrenal withdrawal and adrenal insufficiency. Because vamorolone is a different steroid, it's been a bit tricky to make some of these transitions for some patients. So the key here is that we're really recommending that vamorolone should be started at that full treatment dose of 6 mg per kilo per dose. If you're in the EU, the max dose in the label is 240 milligrams. In the US, it's 300 milligrams. And really, we recommend starting at that full dose, irrespective of the prior dose of prednisone or deflazacort if they were on steroids before. And the reason for this is the 6 mg per kilo was the only dose that really showed parity to prednisone for efficacy on muscle outcomes. And then anecdotally, we have seen some reports in clinic of some patients who've developed weakness and signs and symptoms of adrenal withdrawal when they start at lower vamorolone doses. Likewise, when transitioning back from vamorolone to other steroids, the recommendation is to go to the full dose of prednisone or deflazacort, although because those steroids affect both the glucocorticoid receptor and mineralocorticoid receptor, we probably don't see the same issues. So how do we handle some of the challenges with transition? So there are some cases when you may need to start someone on vamorolone dose of less than 6 milligrams per kilogram. One example, of course, is if you have an older, larger patient whose dose is going to exceed 240 milligrams. Another example is if you have someone who's already overweight and concerned about the weight gain, you might consider starting at a lower dose. In those situations, to be safe, we would suggest considering giving a background hydrocortisone or prednisone bridge at a maintenance dose. And so you would give them that low dose of hydrocortisone in addition to the vamorolone for about 4 weeks, just to provide coverage of some background steroid while they make that transition. and important to counsel families if there's any symptoms of muscle weakness or adrenal withdrawal or adrenal insufficiency to immediately add those stress steroids with hydrocortisone and prednisone. And then likely what you can do is put them on that maintenance dose for 4 weeks and then slowly taper that off. So in conclusion, and some key take-home messages here, adrenal suppression is a serious complication of vamorolone therapy. It's important to educate both individuals and their caregivers at the time of initiation of therapy about this risk. You want to provide stress steroid plans to everybody on vamorolone. Remember that vamorolone cannot be used for stress dosing. Always best to perform a taper when discontinuing vamorolone, and use care when transitioning from one steroid to another. And then finally, engage your local endocrinologist. They're always happy to help. So just want to again quickly acknowledge the optimized group, in particular, Alex Ahmet, Annie Sprocki, Leanne Ward, Jared Wong, who all contributed to the development of some of the figures in this slides. And then here are some of the resources that I mentioned and are available for use.